It's time for another podcast by George. Straight talk, straight from the heartland, that'll have you saying, "By George, I think he's got it." Now, here's George.
Hello. Hi, how are you? Welcome on in to another podcast by George. He's back. The doc is making another house call. It's Dr. Andrew Nish to talk to us, kind of an update here in the great Midwest and the heartland about the situation with COVID. And then we've got another topic medically that we want to talk about. But I kind of wanted to start with just briefly mentioning something. And I say briefly because, you know, the subtitle for my podcast is not a lot of time, just time well spent. You can listen to podcasts that take 2 or 3 hours to get over with. You can listen to podcast hosts on topics you don't really care about, where they sound like they belong to Slow Talkers of America or something like that. But I try to get it out there, and the doc is on point, and he's always ready to go. So I want to bring him in here. But what I wanted to digress right off the top about a little bit. Today is the 80th birthday of Bob Dylan. He turns 80 today. And
I didn't know that.
Yeah, Doc, everybody knows I love Bob Dylan. And I got to mention, one of the first presentations I saw by Dr. Nish, he ended it with a favorite song of his that's from the same 60s era as Bob Dylan. It's Jesse, Colin Young, and the Youngbloods and Get Together. And if you told me that that was the greatest song ever recorded, I wouldn't argue with you. As much as I love Bob Dylan and other artists, what a great song. So I know we've got that in common as far as that era of music is concerned. But happy birthday, Bob Dylan. I'm not going to talk about it any more than that. And the one guy that would be all right with would be Bob Dylan. He doesn't like that kind of stuff either, so we'll just leave it at that.
Where's Bob Dylan from?
Bob Dylan is from the Iron Range. He's from,
Yes.
up there.
In Minnesota.
Yes, and his folks owned a furniture store, and he started in a high school setting like a lot of these young musicians do. He went to the University of Minnesota briefly, and then he stuck out his thumb and went to New York and ended up, that was the beginning of where he is today. But that'll be the subject of another podcast. Like I say, I don't want to get too far off topic here. I just wanted to mention that it was Bob Dylan's birthday. Well, Doc, if you could, just to give us kind of an overview, I guess my first question is what's on everybody's mind. Are we continuing to trend in the right direction with COVID? Are things improving? I've seen some statistics that say we're kind of where we were at this time last year. Is that correct?
So we're below 30,000 cases a day in the United States, 28,000 and change. And that's the lowest we've been in 11 months. So we are improving. The number of cases is down, the number of deaths are down. Vaccinations are continuing to go up, albeit slower than they were several months ago. And, so we're in this country, we're doing okay, but I think we have to be cognizant of what's going on in the rest of the world. And because, we're going to start traveling in international travel again. And, the rest of the world continues to struggle a bit, particularly countries like India and, other third world type of countries. But we're doing okay in this country. Could we do better? Sure, we can always do better. But caseloads are down. When I looked at our census last week at the hospital, we had 10 COVID cases. That's the lowest it's been in almost a year. So.
Well, that's great. I hate to be a negative Nelly on this thing, but I kind of look at that and well, wait a minute. Like you said, it's the best we've been in 11 months, but I remember a year ago at this time, we were really worried. We were terrified, but it's all about the trend lines, I guess. The trending is what's most significant, correct?
Yeah, so we're trending down. We haven't seen any, big spikes. We do want to try and get more people vaccinated. And there's been this question of, are we not getting people vaccinated because there's vaccine hesitancy? But I read a really interesting piece by the former head of the CDC under the Obama administration, and his name is Friedman. And he was talking about, it's not so much vaccine hesitancy right now, it's actual access to the vaccine. And there's plenty of vaccine to go around, but people are having a hard time getting off work to go get the vaccine. And it may be that we have to bring the vaccine into workplaces and just vaccinate people at work. So it may not necessarily be the hesitancy of, I'm not going to get the vaccine, but it may be, how do we actually get workplaces to make time to get people vaccinated? So, do we know perfectly why people aren't getting vaccinated? No. But, other countries, they go door to door and vaccinate. And we make it somewhat more difficult in this country because you have to travel to the doctor, you have to travel to the pharmacy. And so really, we're talking about physicians messaging this with their patients and making sure that their patients get vaccinated. We need to make the vaccine more accessible to people. That seems to be the word right now. How do we make it more accessible so people don't have to take, half a day off to go get a vaccine?
Well, let's do some quick hitters here. I want to bring this up on screen, and this is always never a certainty. Let's see how we do here bringing this up. Now, this is an article from the USA Today by Nicole Carroll. She's the editor-in-chief of USA Today, which I didn't realize from over the weekend. She says vaccinated people aren't ready to shed masks. She says the mask wars aren't over. The Centers for Disease Control and Prevention has relaxed mask guidelines, saying fully vaccinated people don't need to wear a mask in most cases. But many plan to continue anyway. This week, retail reporter Kelly Tyko asked our readers, if you're fully vaccinated, will you still wear a mask shopping, even if not required? About 60% of the 541 respondents said yes. Currently, 37.8% of the total U.S. population is fully vaccinated. That rises to 47.9% of people 18 and older and 73% of us geezers 65 and older. The CDC recommends unvaccinated people continue to wear masks to stop the spread of COVID-19. She says, I don't trust other people with being honest about their health. That's a reader from Santa Clara, California. And I don't want COVID under any circumstances. So that reader to USA Today is going to continue to wear a mask. And I guess, Doc, you would say that's A-okay. That's just fine.
Absolutely. I mean, you know what? If people want to wear a mask, there's nothing wrong with wearing a mask. And, particularly, I would encourage it in enclosed places with many people because you don't know what the mix of people are. And you may be fully vaccinated, but we know that the vaccine is not perfect. So a small percentage of people will end up acquiring COVID. So, if people want to wear masks, go for it. Masks will also protect against other infectious diseases, common cold, flu, and things like that. So, for me, mask wearing may become part of my life during the winter flu season. If I go to a big public event that's crowded with a lot of people, I may choose to wear a mask. Who knows?
Well, I think that's been proven that that indeed is the case. So that's one upside, if there is any upside to COVID. Now, I want to continue with this. Let me bring this up. Some parents are also confused by the CDC guidance, it says. Others told Nation reporter Christine Fernando they feel left behind. Speaking about the relaxed mask guidelines, for me it wasn't a time to celebrate, said Janie Abel, a mother of two 7-year-old girls in Omaha. My husband and I are vaccinated, but what about my children? I absolutely don't trust people to do what's right and wear their masks if they're not vaccinated, she said, and that's going to put my children at risk. Okay, I wanted your opinion on that because the question is, does it really put them at risk? Are children at risk? I think they are, but at a much reduced risk, right?
Yeah, much reduced risk to actually have any severe COVID symptoms. And the transmissibility, we're still kind of studying that. It is a bit confusing with the CDC. What can I do? What can't I do? Kids are going to be out of school in a week and a half around here. They're going to go about their summer activities, and hopefully by fall, we'll have a good proportion of kids vaccinated. There's some trials going on with the younger children, age 2 and up. And those trials probably will be completed by the end of the summer. So by next fall, we should have a lot of kids vaccinated, and this probably won't be a big issue, I guess.
I wanted to end here with the closing comments in this article here. This is from health editor Jennifer Portman. Again, this is from USA Today. She's been covering the conflict from the start. She says, I'm concerned that the CDC doing this may have created more confusion at a time when we didn't really need to have more confusion. She said, it's just sowing more deep division between the masked and the maskless. I'm hearing that kind of thing too, but I don't know. Is the CDC kind of in a can't win situation here? Are you confused? Is confusion a major issue in your mind?
I think the CDC did this to really promote people to get the vaccine. They're saying, if you are fully vaccinated, look at all the things you can do without a mask. And so I think that, is their recommendation perfect? We don't know. And that's only retrospective that we're going to figure that out. But I think their real purpose was look at the things you can do if you're fully vaccinated to help people move beyond vaccine hesitancy and actually get the vaccine. So,
and this next article, and I'm trying to get through these things quickly. I wanted to bring
that article is opinion. That's someone's opinion.
That's correct.
I just discount opinion. We have lots of opinions. We're not going to know whether the CDC recommendations were good, bad, or indifferent for months. They're doing the best they can. I trust the leadership of the CDC. Dr. Walensky is an infectious disease expert from Harvard. She's doing a great job, in my opinion. They're doing the best they can with the data that we have. So,
well, this next article from the New York Times is not opinion. And when I saw this, I thought of you because you were talking about this months ago on this podcast. This is from David Leonard in the New York Times, the venerable New York Times. But you've even got to look at that subjective. Like the doc says, you have opinion. The New York Times is an example. I'm always jaundiced when it comes to the Times because they supported the Iraq War. But Leonard says the biggest vaccination gap isn't based on race or partisanship. It's based on class. It is common to hear about two different demographic groups that are hesitant to receive a COVID-19 vaccination. And this is how a lot of people think about it. Republican voters and racial minorities, especially Black and Latino Americans. The two groups seem to have different motivations. For Republicans, the attitude is connected to a general skepticism of government and science. For Black and Hispanic Americans, it appears to stem from the country's legacy of providing substandard medical treatment and sometimes doing outright harm to minorities. Now, he says these ideas have some truth to them, but they also can obscure the fact that many unvaccinated Republicans and minorities have something in common that we need to think about. They are working class, and there is a huge class gap in vaccination behavior. And here's a look at vaccination behavior by racial groups and political identification based on polling by the Kaiser Family Foundation. And I'm going to bring this little chart up and ask the doc to comment on this. Because, again, this is something that he was talking about months ago. Now, at the top of this chart, vaccine attitudes, look at the groups here of those that are vaccinated ASAP or wait and only if required or definitely not. You look at that, and there's your Democratic-Republican split. But then move down the chart, the same group subdivided by class, using a 4-year college degree as the dividing line between working class and professional. And it is striking when you look at it in that context. And a lot of people don't look at it that way. And I talk about this a lot on my podcast, Doc, that the problem in America isn't necessarily Republican and Democrat. It isn't necessarily left and right on so many issues. It's actually a class struggle. Those at the top and those at the bottom, those with the money, those with the education, those that don't have it. And it appears, if you look at that graph anyway, that that is strikingly true when it comes to vaccinations and the situation with COVID. Am I on the right track here?
Well, I think so. And I think that ties in perfectly with the statement I made earlier that Dr. Friedman talked about, that we're not vaccinating as many people because we're not getting the vaccines to where those people are.
Yes.
So you take the lower class people who are in the factory jobs, who are in the meat packing jobs, who are in the lawn service jobs. They can't get paid time off to go get a vaccine.
Yes.
So what do we need to do? We need to bring the vaccine to them. So we should be bringing vaccines to large factories and say, hey, we're going to vaccinate everybody today, or bring it to, for hotel workers or whoever. So I think that that's where we're seeing, that class discrepancy. As professionals, we may have the time to say, hey, I'm going to take an hour at lunch and go get my vaccination. But if you're mowing lawns or you're doing, childcare, or you're doing hotel maintenance and things, you may not have that luxury. And so that was his point exactly, that we've made it too hard to get vaccines. We should make it really easy that, here you go. Where the vaccine mobile is at your factory today. Line up and let's go.
Well, that segues very nicely into another topic, because there's other major medical news going on right now that affects a lot of my viewers and listeners. And it's affecting more Americans because of the age recommendation for this. And I wanted you to talk about that a little bit. Tell us what's going on with these colonoscopies that everybody dreads and that the older folks have got to get. Yeah.
Yeah. So back in 2018, the American Cancer Society changed their guidelines for colon cancer screening from starting at age 50 to starting at age 45 for average risk adults. The United States Preventative Services Task Force came out last Thursday and said, or Wednesday, whatever day it was, and said they agree with that we should be starting screening for colon cancer at age 45 for average risk adults. And when I say average risk, that means you have not had previous colon cancer, you haven't had previous polyps that predispose you to colon cancer, you don't have a genetic syndrome or a family history of a genetic syndrome that predisposes to colon cancer, and you don't have inflammatory bowel disease. So why did that change? Why did we go from 45 to 50? Well, if you look at the last decade, the incidence and death rate from colon cancer in people 65 and over has declined at about 2% per year, 2 to 3% per year. If you look at age 45 to 50, the incidence of colon and particularly rectal cancer has increased between 2 and 3% per year. So we're seeing an increase in incidence, meaning actual colon cancers in the 45 to 50-year-old age group, and we're seeing an increased number of deaths in that group. So the United States Preventative Services Task Force reanalyzed the data and made the recommendation that there's a moderate chance that the risks or the benefits of colonoscopy or some screening test at age 45 to 50 outweighs the risks. So when you look at, colonoscopy, with the United States Preventative Task Forces, they give it a grade A, B, C, or D recommendation. An A recommendation is that there's a very high likelihood that the benefits outweigh the risks. A B recommendation is there's a moderate likelihood that the benefits outweigh the risks. And so they gave screening 45 to 50 a B recommendation, whereas 50 and over is an A recommendation. But a B recommendation means, yes, it gives it the green light for screening of those people.
Well, I've been doing this for a while, so I can tell, it's not pleasant, but it's something you need to do. And like he says, the benefits far outweigh the risks. It's kind of like vaccinations or anything. I mean, hell, you don't want to do this type of thing, but you need to. But let me see if I've got this right. So if you're just an average Joe or Joan out there and you don't have any family history of colonoscopy particularly, or you haven't been diagnosed with issues.
Colon cancer.
Colon cancer. Colonoscopy. Yeah, colon cancer. And so you should start this protocol at age 45. And if you have a history of colon cancer or some of these other issues you mentioned, even before then.
Yeah, you have to talk to your doctor, and that's very individual. So we're not going to make any blanket statements. But if you have a question, my dad had colon cancer at age 50 or whatever, you need to talk to your doctor because there's other recommendations based on your history.
And how do you assess the role of screenings thus far when it comes to colon cancer? Is it helping bring that rate down? Or
no question about it. The epidemiologic data is very conclusive that screening not only decreases the incidence of cancer because we're finding these precancerous polyps that we take out, it's also lowering the number of cancer deaths. So you have to remember that colon rectal cancer, if you take both men and women, has gone from the third to it's the second leading cause of cancer death now. But it's still, we've seen a decreased incidence over the years because of screening. About 68% of the population is actually getting screening. So we still have a ways to go to improve our screening rates in the population. But now that population is going to expand because we're going to go down to age 45.
So
And there's multiple ways to screen. Colonoscopy is the gold standard, but there are stool-based tests. So you can get a test for blood in the stool. You can get a test for blood and DNA that's shed by tumor cells. But if those are positive, then you got to go to colonoscopy.
And I mean, this has been your life. I mean, treating folks with cancer. Why is colon cancer so lethal, basically?
Actually, it's not as lethal as lung cancer. We've made some pretty decent progress in our treatments over the past, 5 years. But the main thing about any cancer, and particularly colon cancer or lung cancer or breast cancer, is the earlier you catch it, the more likely we are to be able to cure you. So that's the whole idea behind screening, that what's called stage migration. Instead of catching a colon cancer in stage 3 or 4 when it's spread to lymph nodes or spread to other organs, we're catching it when it's confined to the colon. If you take a stage 1 colon cancer, which is a colon cancer confined to the colon, the 5-year survival rate is well over 90%. It's a treatable, curable disease. If you take stage 4 colon cancer that's already spread, it's not curable, it's treatable, but only about 10 to 15% of people live after 5 years.
Well, I've got a kind of an unusual perspective on it. My mother died of adrenal cancer. I mean, that's where it started with her, I think. And anytime somebody tells me that they've gotten cancer or a relative that's got, the first thing I want to ask them, did they smoke? Doc, I think smoking affects every form of cancer, every type of cancer. Am I wrong in that, or is that...
Not every cancer, but there's a lot that do, and colon cancer is one of them. So when we look at any cancer, we look at modifiable risk factors, those that you can change, and non-modifiable risk factors, those you can't change. So what are the non-modifiable risk factors for colon cancer? Well, one of the biggest non-modifiable risk factors for any cancer is age. Cancer is a disease of older people mostly. So age. Men get colon cancer more often than women. And then if you have a genetic predisposition, so you have a genetic mutation that predisposes you to colon cancer, but that's a very small portion of the population, less than 10%. So then we have to look at what are modifiable risk factors. So what are the risk factors for colon cancer? Overweight and obesity is a definite risk factor for colon cancer. Physical inactivity is a definite risk for colon cancer. Our great American diet, it's low in fiber, low in plant material, is a risk factor for colon cancer. Smoking is a risk factor for colon cancer. Diabetes is a risk factor for colon cancer. So we think that over 50% of colon cancers are potentially preventable. So, it goes back to all these chronic diseases you and I have talked about, whether it's colon cancer, whether it's lung cancer, whether it's heart disease, stroke, dementia. These are all lifestyle related. And so we need to eat more plants. We need to get out and move. We need to quit smoking. And the other thing that's a risk for colon cancer is excess alcohol use. So what is excess? More than 2 alcoholic beverages a day. Alcohol, we nuanced alcohol for years. Oh, it's okay to have 1 or 2 drinks. There was just a big study out of England that looked at alcohol use in thousands and thousands of people over time. And what they concluded is there is no safe level of alcohol use when it comes to long-term cognitive function and dementia.
Wow. Well, I saw a guy, an expert, he says, it's pretty simple. He said, intoxication, intoxic. It's toxic. It's poisoning you, basically. And if you overdo it, you're putting yourself in a toxic state. Yeah.
Just like anything in life, there are, it's all dose dependent. So if you have, 1 glass of red wine a month, probably of little consequence. If you're having 3 a night, big consequence. It's the dose. Just like sugar, right?
Yeah.
It's the dose. The dose of sugar is toxic when it exceeds certain levels. The same with alcohol, but our threshold is getting lower and lower for understanding that alcohol it's a neurotoxin. I mean, when you drink a glass of alcohol, a certain percentage of that alcohol is going to your brain, and it's a neurotoxin. Plain and simple.
Well, we started off talking about the great Bob Dylan, and it's his 80th birthday. They asked Bob one time his recommendation on health. He said, eat a pepper a day. But Bob, Bob Dylan would be the first guy to say, why are you asking me? I mean, he never understood why people would come to a song and dance man, a guitarist, a singer-songwriter, and ask him about issues like that. Well,
it's sort of like Keith Richards asking him for health advice,
yeah,
right?
Exactly.
Just because he's 80 years old doesn't mean that he did so well in that.
Yeah.
In fact, it's a miracle that he's 80 years old. Right?
God, people are something else. Well, Doc, just wrap it. I'd like to give you the last word here. Give us a little closer because we're out of time.
As I always like to say, we all need to be grateful for where we are in this pandemic because it could be so much worse. So give gratitude to the scientists and the healthcare workers and everybody who has made the vaccine and the availability of the vaccine possible, because it's an absolute game changer. And without it, I don't know where we'd be.
That's a great closer. I can't think of any better way to wrap up than that. We got to send him on his way. Folks, that's Dr. Andrew Nish. And if you like Podcast by George, if you like this information, these facts, if you like some of the opinion that's in here from me particularly, like Podcast by George wherever you find it, on Facebook or on YouTube. Subscribe there. iTunes is another place where you can get the audio versions. We're basically just about any place podcasts are seen or heard. But that's going to do it for this one. That's going to wrap it up. That's all there is. And there ain't no more. That's another podcast by George.